welcome to Montefiore Cardiology. Good afternoon and welcome to Montefiore Cardiology. It is an absolute honor for us to have Dr. Benjamin Hirsh here with us this afternoon. He will be speaking with us about cardiac rehabilitation, time to rebrand and reinvigorate virtually. Dr. Hirsh earned his undergraduate degree from Northwestern University, his medical degree from Emory. He did his medical residency at Columbia here in New York City, and his cardiology fellowship here in New York City at Mount Sinai. He is currently at Northwell Health, where he's an assistant professor of medicine and the director of preventive cardiology and lipidology, and the founder and medical director of cardiac rehabilitation in Great Neck, and I believe throughout the Northwell system. Dr. Hirsh is a highly sought after speaker, having given multiple presentations nationally, and he's involved in numerous academic organizations, including the AHA, where he's a member of the Atherosclerosis, Thrombosis, Vascular Biology, and Lipidology Scientific Committee, and the ACC is a member of the Diabetes and Cardiometabolic Committee, and a working group, and also the American Society of Preventive Cardiology. He's an awarded mentor, and he has published many articles in journals such as JAMA, JACC, and Circ Heart Failure. Just as an aside, we will be having CME credit for this talk, and the code for that will come up at the end of the talk. It's an honor for us to have Dr. Hirsh with us here today. Thank you for joining us.
Thank you very much, Robert. That was a really nice introduction, and I appreciate the opportunity to present to you guys. Appreciate the entire faculty for the opportunity. So I will be speaking today about a class 1 exercise-based therapy that is very effective but highly underutilized. Thanks to virtual technology, cardiac rehabilitation is being reinvigorated and will be more accessible to our patients. The goals of my talk will be to review the need for cardiac rehabilitation as an essential therapy that has been relegated for far too long, to review the evidence base for using a virtual platform to deliver cardiac rehabilitation and why there's such a need to do so, and to discuss the strategies necessary for health systems to adopt this technology and address patient-provider concerns regarding this technology. So moving on to a brief, broad overview of cardiac rehabilitation in general, and in the context of the burden of cardiovascular disease on our patients and healthcare costs in the U.S. in particular and across the world. So as you can see on the right, since 2000, ischemic heart disease has been the leading cause of death and is increasing and continues to widen the gap in comparison to other causes that are now responsible for over 9 million deaths a year worldwide. During the height of the COVID pandemic, more people died of COVID than actually any other cause except heart disease. So addressing heart disease is obviously a top public health priority. But we are not investing in prevention even after identifying the disease. The bottom of this cardiovascular pyramid is really a poorly funded cardiovascular prevention base related to low reimbursements and underutilization, despite the need for prevention to reduce the disease burden. So in essence, we have a pyramid standing on its head, where revenue and reimbursement primarily support advanced procedures and select few patients at advanced stages of disease. Now, the ACC, AHA, CMS leaders, CDC, and other stakeholders, as well as think tanks, are recognizing this and developing initiatives and goals to address this increasing burden. So what is one underutilized way to reduce this burden? How about exercise, or even avoiding prolonged sitting, which in and of itself, by the way, is the independent risk factor for heart disease. So this study on the left was published in 2017 in the journal JACC. The authors looked at about 16,000 patients who had stable coronary heart disease and examined the effects between exercise and mortality. Patients filled out questionnaires at baseline on the amount of physical activity and were followed for a median of 4 years. They found, as shown on the left, that there was a graded decrease in mortality, increased physical activity, and the highest benefit was seen in that first part of the curve. That is, the greatest benefit was seen amongst those who went from being sedentary to being physically active, as with increasing volumes of physical activity yielded additional benefit, but the absolute or incremental decrease in mortality became smaller for every doubling of exercise volume until it sort of plateaued. So numerous studies have shown these same results. The more you sit, the higher your risk of shortening your lifespan. The more you exercise, the greater your chances are of increasing your lifespan in both primary and secondary prevention. And despite this, cardiac rehabilitation is very underutilized. Currently, the national capacity for us to use cardiac rehabilitation is 30% of eligible patients at a conventional center-based cardiac rehabilitation. So current referral rates are actually about 50%, but amongst those who enroll, about 25 to 29% of Medicare beneficiaries age over 65 actually enroll. And then amongst heart failure patients, 10% of eligible patients have enrolled. So really, when you start to multiply these numbers, about 50%, so over 36 sessions, those who actually completed is about 50%. So that translates to about 8 to 10% of eligible patients actually cardiac rehabilitation. And personally, I think these numbers are overestimated. But cardiac rehabilitation is very effective, with benefits seen early on and continuing to accrue over time. In this study that was published in JAMA Cardiology, they looked at a total of about 40,000 Medicare beneficiaries who underwent cardiac surgery. Cardiac rehabilitation enrollment was associated with fewer hospitalizations and mortality at the point of history. And this is even after they adjusted for numerous variables, including type of surgery, age, gender, race, region, income, and length of stay. So they looked at all of these and they saw that it's still helped. And just another slide here, some other examples demonstrating very low enrollments in general and under 10% of people actually completing cardiac rehabilitation, with women enrolling less and completing less. On the right is a slide that shows that mortality is improved with cardiac rehabilitation users versus non-users, and even among users, cardiac rehabilitation, the more completed sessions, the lower the mortality association. So we need to identify and overcome barriers to expand access. The Million Hearts is a CMS affiliate organization. They have been tasked with the initiative to produce 1 million heart attacks and strokes by the year 2027. Prior to the pandemic, the largest of their strategic goals is to require to accomplish this mission, which is being done in alliance with a number of organizations, see on the right, the ACBPR, Agency for Health and Research and Quality, the CDC, is to increase enrollment in cardiac rehab to 70%, so they can fill that gap that you see on the left slide, and fill that gap in enrollment and increase enrollment. So they plan to do that through expanding access to home-based or virtual telehealth models. Obviously, COVID has been terrible both for its primary effects and its secondary and downstream effects on healthcare. But it also forced us to rethink how we can deliver healthcare. And when everything shut down, cardiac rehabilitation either shut down or were forced to pivot. to delivery of cardiac rehabilitation through a virtual platform. So we are now accelerating this trend to address a longstanding health debt patients who need cardiac rehabilitation. To be at the forefront of cardiac rehabilitation, we don't need more physical space. We need to be very intentional, comprehensive about building a virtual platform program. So conventional cardiac rehabilitation model is not sufficient for a number of reasons, as you might suspect, including the limitation of our current national physical space, patient access, which includes timing of rehab sessions. So what time are they able to attend? The distance of rehab from home. And this is at a time when there's increasing number of patients need to be. When do we start exercising after heart attack? Most people don't know the answer to this question. Most cardiologists don't know the answer to this question. And most patients then go on to think that they need to take some time to recover. What's interesting is that most patients do not have an idea about when it is safe to engage in activities such as exercise, returning to work, or even having sex, having a myocardial infarction. Really, patients should be exercising within 5 to 7 days after discharge, unless patients demonstrate symptomatic valvular heart disease, congenital heart disease that prohibits exercise, decompensated heart failure, and other comorbid conditions that could be worsened by exercise. So assessing these comorbidities, physical limitations, is one of the many reasons why cardiac rehab is strongly encouraged. And another reason why patients should be enrolled as soon as possible after discharge in cardiac rehabilitation. So what we need systems and providers to support this, because each day, as shown on the right, a person who is not enrolled reduces chances that they will enroll. And the strongest predictor of participation is the strength of a physician recommendation. And these programs are especially important for people with greater barriers, which I will discuss, which include living greater than 30 minutes from a CR center, as an example. But often overlooked, these programs are not just exercise-based programs. Significant benefits are derived beyond exercise as well, and this is important. We have to endorse the concept that exercise therapy is a component of cardiac rehab. Certainly, it's probably the major component, but it's in addition to numerous others that include addressing stress management, nutritional counseling, adherence to medications, diabetes management, and all of these things that empower and educate patients to really make a lasting change in their lifestyle habits. And because of recent data demonstrating similar quality of life, similar cardiometabolic outcomes, hospitalization, mortality outcomes for both conventional and virtual models, we now have an evidence base to fill that gap there with virtual models. So some have raised a concern about whether there is equivalency or similarities in outcomes in exercise training or cardiovascular rehab done in virtual setting or a conventional setting. So this is a meta-analysis where they compared functional capacity and health-related quality of life in outcomes in heart failure patients. They identified 30 randomized controlled trials with a total of 2,000 heart failure patients and compared home-based cardiac rehab versus usual care. Both home-based and home-based cardiac rehab significantly improved functional capacity compared with usual care. Home-based cardiac rehab also improved health-related quality of life. So moving on, we need to talk about how about therapies that actually compare home-based to conventional cardiac rehab. One more home-based one compared to usual care. In the study on the left, this is done at VA, where they completed a 12-week home-based program over 18 months. And this was geographically dispersed over, I think, 25 hospitals. The results of 1,000 veterans who were enrolled and the ages were in the mid-60s. About 550 of them completed it. The findings included significant improvements in exercise capacity, depression, symptomatic walk tests, and understanding of their medications, as well as body mass index, eating habits. On the right is a study that was done at a Henry Ford Health Center. This is done by Stephen Katayan, who's kind of one of the most well-known physicians in the cardiac and virtual cardiac rehabilitation space. He compared exercise training during standard cardiac rehab against home-based cardiac rehab by % heart rate reserve changes throughout cardiac rehabilitation sessions. And what he saw was that there was no significant difference among 75 patients. Despite the small sample size, he said, our study is operationally important as it provides practical information that addresses the concern that is sometimes voiced about the home or community-based component of hybrid CRM. Specifically, the patients that exercise at home do so at a lower exercise intensity when compared to clinic-based only cardiac rehabilitation. We trust that our observations to the contrary will support and guide the expanding momentum to develop and evaluate alternate models of cardiac rehabilitation. We acknowledge that our model of cardiac rehabilitation using telehealth may not be feasible for some programs. That said, due to the COVID-19 pandemic, most health systems are now better prepared to assist cardiac rehabilitation program staff and operationalize a virtual or remote cardiac rehabilitation model. So moving to the next slide, this study comes from a Cochrane database systematic review, which compared center-based cardiac rehabilitation with virtual programs for eligible patients. This study included over 20 trials, randomized 3,000 patients undergoing cardiac rehabilitation. There was no difference between virtual and center-based cardiac rehabilitation clinical primary outcome over a 12-month period. Also, there was no significant difference in exercise capacity, quality of life, and so the authors concluded that that improving clinical outcomes and health-related quality of life is similar amongst patients who are eligible for cardiac rehab and between conventional versus virtual model. Moving on to the next slide. This study was published in JAMA Open Network actually 3 months ago. It was a retrospective study that was done at a project from Momentum, and it compared virtual versus center-based higher risk patients more complexities than previous studies. Seemed to look more at low to moderate risk patients, and also more demographically diverse patients. They compared hospitalizations, medication adherence, and cardiovascular risk factor control between patients who underwent virtual versus conservative rehabilitation. They included 2,500 patients over a year, and actually what's interesting is unexpectedly, you can see on the right there, that patients who received home-based cardiac rehab had lower odds of hospitalization 12 months. And otherwise, there were similar odds of adherence to beta blockers, statins, blood pressure, LDL, A1C, and 12 months. So these findings actually suggest that home-based cardiac rehab can be effective for demographically diverse populations, including patients who are at higher risk, who are kind of more medically complex, and it's associated with fewer hospitalizations in 12 months, compared with patients in conventional cardiac rehabilitation. So the study further strengthened the evidence that we should support home-based cardiac rehabilitation. And this was actually the first study to show benefits, not just non-inferiority. Now, it was a retrospective study, and data from the demographically diverse population, patients who are medically complex, was lacking, but it was a strong sample size. So there's certainly more work needs to be done in this field, but the evidence is showing at least similar improvements on all metrics between these two models. So how do we implement this model in a health system with or without using third-party vendor? So to do this, the first identification, first you identify your goals and strategies, which includes developing a strategy and operational workflow that will optimize enrollment and participation, defining the structure of a new care delivery model, implementing virtual delivery platform, effective technology solutions, and then ultimately improving the patient experience and practitioner experience using feedback to improve. So this is not necessarily the best model. It's the model that we generally use. It seems to be effective as long as you have appropriate support. So to walk you through this slide of how we get patients into cardiac rehab and increase eligible enrollment, we identify eligible patients, eligible inpatients and outpatients, and then to optimize inpatient enrollments, we have educational materials that we provide them with at time of discharge, and an automated referral funnel. They're then screened by the cardiac rehabilitation staff, and it is not their cut whether or not they should go to virtual versus conventional cardiac rehabilitation. But overall, there's a higher risk, the high risk patients who can do, for example, less than 3 meds, more frail, and or higher risk, multiple comorbidities, or they lack familiarity with technology. They have an LVAD device, or they're less than 30 minutes from home, and they may want to be on site and have a more flexible schedule. These are people who would maybe want to do conventional cardiac. Likewise, the factors that favor virtual cardiac rehabilitation include low to moderate risk patients, familiarity with technology, and transportation issues such as living greater than an hour from home, or schedule conflicts, and not having a home appointment. So they may want to actually do it from home because they have it, but that's really not necessary. So in addition, we believe that they need something to go home, and that will keep this at the forefront of their mind when they leave the hospital. So fortunately, we've had supportive donations, and we're able to provide the patient with swag, including personalized handouts to provide an overview of cardiac rehabilitation, as well as water bottles, t-shirts, pens with Buffalo branded virtual cardiac rehabilitation slogans. So the handout really kind of breaks down the process nicely for the patient as to how their enrollment and progress will work as I outlined. So what happens to that virtual patient? So the patient gets enrolled, and the patient has 2 touch points at the intake, and that can be completed telehealth or virtually and in person. The initial intake, they go over the goals, barriers, and then at the program end, it's the second touch base. They're introduced to the Microsoft Teams platform curriculum. We get baseline metrics such as 6-minute walk test, incremental protocol, depression, food intake, and then we customize or develop an individualized treatment plan, which looks at their meds, the limitations, and their home environment. And then we schedule them. We identify a safety plan, and ensure we have the correct patient. And then, as I said, we go to small environment to ensure it's. We then reassess whether this patient is still appropriate for commercial cardiac They then undergo goals, whether they're in telehealth or virtual cardiac rehab, and these are the kind of SMART goals, but they ultimately kind of develop their own goals so that they're really kind of trying to achieve their own victory. We have an exercise class that's led by an EP, which is the same as in telehealth, as in conventional. And we have again safety plans, and then for each class, the symptoms are checked. Symptoms to make sure that the patient's not having any symptoms, etc. So we really try to recreate that in-person environment on a virtual platform as much as possible. Then they're also educated on videos, which we'll discuss in part of the session, 5 to 10-minute discussion. Progress is reviewed monthly to increase the workload, and exercises are geared towards exercises without the need. And I'll get into more of it: walking, stretching, bands, calisthenics, and then we measure their heart rate, their rating of perceived exertion, and we do that at the end and compare it to just we do conventional. So there are numerous. Basically, this is an example of what we're using. There are numerous vendors out there who are trying to bring this to health systems. Thanks to support, we chose to build our own and use Microsoft Teams, just as we're using with all telehealth business currently. So people often ask, how does this work? How do you exercise at home? You're skeptical, and what kind of patients, or what kind of exercise are these patients doing? And there's really an entire science dedicated to home-based effective aerobic activity exercises for different patients that are customized to limitations and goals, whether they have equipment at home or not. And remember, most of these patients exercise very little when they begin. So even just some aerobic activity is beneficial for them. But we're able to really customize an individualized treatment plan at home that does allow them to progress. So this is just another illustration of various exercises without the use of equipment. You could do knee lifts, wrist walk, step ups, and just to show on the right here, a 10-minute indoor walk for seniors. There's a whole science to go to this, with bands and just numerous ways. And my exercise physiologist would be able to kind of speak to that more, but they're seeing that patient improve. Again, here's another illustration of various exercises without the use of equipment. We incorporated both aerobic and resistance training with bands provided to support. So this is just to show that we really customize it. And even another illustration, that even in patients with limiting factors such as osteoarthritis, it's even more important that they have this individualized treatment. But it's also more important that they need to be active. So we customize this therapy for them so that we can provide an exercise or an exercise plan for them. They can provide benefits to others, even with limitations such as osteoarthritis. So now moving on to curriculum. Basically, we are creating a 12-part video series that's designed to guide patients through different aspects of virtual cardiac rehabilitation. The primary goal of this series will be to increase patient adherence and address lifestyle and risk factors. We intend to make these videos kind of exciting, to encouraging and fun, more movement oriented in order to kind of overcome that huge hurdle of patient adherence. Each video will be customized for the information that needs to be presented, whether it's smoking cessation, nutrition, balance, exercises, cardiovascular fitness, etc. This series will feature multiple staff members as experts of the perspective. So here's some examples of what our video education looks like. And they address, again, many other critical aspects beyond exercise. So identifying the goals and then learning about the importance of things such as medication adherence, what we hope and they'll derive from these educational videos. And these are going to be provided to patients, actually, whether or not they're enrolled in conventional versus telehealth program. So for patients who are not enrolled because of insurance reasons on discharge, they're still going to be able to access these videos so that we can, in some form, provide them a way to understand their health, understand what's to it's also technically called asynchronous cardiac rehab plans, not done for telephone. So more examples again, nutrition, which I feel is really absolutely critical, and it's one of the most important aspects of education. This includes videos on food labels. How do you read food labels, and what's important from the food labels that you're reading, as well as what kind of general should you be including in your shopping bag. And so basically these are videos to really try to help patients change their lifestyle to derive benefits from that beyond exercise. More videos again. What do you do when most people eat out? What do you do when you eat out? What kind of things do you avoid? How can you do it safely? So that's part of education, as well as education on types of exercises that we're incorporating in our classes. So how about the future of virtual rehabilitations? What does that entail? What does it look like? What does it evolve? So more than ever before, there's been an unprecedented reason to look to innovate and consider other emerging health services, such as remote physiological monitoring. And this is for translating kind of these progressive concepts of virtual cardiac rehab into a more contemporary and cost-effective and sustainable service for these patients. So Medicare beneficiaries of all socioeconomic backgrounds can derive benefits, but these new models can change how CR or cardiac rehabilitation is delivered. The new models should not change what is delivered. So it's what, again, cardiac rehabilitation should never be the core components of the cardiac rehabilitation program should never be compromised. It's a multidisciplinary program, addressing all of the things that we discussed. So we have a plethora of new technologies, and everybody's kind of interested in the new gadgets, how they can utilize kind of this transformation of digital healthcare. But we have to really be careful and have to ask ourselves 3 questions in my mind. The reliability of these devices, are they FDA approved? And importantly, do these devices address and improve outcomes or cardiovascular rehabilitation outcomes individually? And then how do we integrate them into our existing systems so that they don't kind of compromise our workflow and create confusion and create data that we don't necessarily. So if we find that these devices answer those 3 questions, then they can be improved. So just to show you a case point, and sorry, this is a little bit of a fuzzy slide, but this is a recent study that looked at the effectiveness of different devices and how they improve different metrics. So it was a systematic review, and they identified the key components of cardiac rehabilitation on the left, and which ones were successfully addressed through digital interventions. They basically describing gaps in research that need to be addressed for these technologies to be both effective and scalable in digital cardiac rehabilitation interventions. So far, interventions have primarily focused on physical activity, counseling and exercise training, and really these devices have not addressed some of the other core components, which include tobacco cessation, diabetes, weight, quality of life, depression scales, things that really matter that are addressed much more effectively with conventional or comprehensive cardiac rehabilitation. So in order to build this, we have to work with others in the community nationally. So we've developed a relationship with Larry Sperling, who's at Emory and is director of Million Hearts Foundation that I discussed earlier. Alexis Beatty at UCSF, Thomas Randall, Mayo, and Steve Catane at Emory Ford. These are the people that are really kind of the key leaders pioneering virtual cardiac rehabilitation to fill that gap. And they've been very generous of their time in helping us with our Sarah Seamers, who's our program director for cardiac rehabilitation, has really been a pleasure to work with a true leader who brings endless commitment and energy to our program, as well as other staff from cardiac rehabilitation team, including exercise physiologists, nurse practitioners, and other administrators. Our administrators, Ruben, Chair of Cardiology, Christian Adams, and Janice Kim, all of them are working tirelessly to overcome hurdles and to change people's behaviors and have positions for more rehabilitation. And also to generous donors such as Victoria Bjorklund and Rachel Sands, who have really helped us get a lot of these things that patients need in order to be interested and to adhere to cardiac rehabilitation, amongst many other initiatives that we're doing in cardiac rehabilitation. So my predictions are that virtual or hybrid services will continue to provide comparable outcomes to center-based home services. That digital technologies and apps will improve continued exercise adherence and lifestyle changes even after course completion, leading to even greater outcomes. And just to wrap up, again, there is a need for change to reduce the burden of cardiovascular disease, and there's a push to adopt virtual technology to provide access to cardiac rehabilitation, which we have to remember is class 1 ACC/AHA endorsed therapy. It's highly effective, but it's underutilized. And the digital transformation of health will improve access, efficiency, outcomes for cardiac rehabilitation. So I'm just going to end with this kind of last slide, which is TV personality star Jones said, who is a major advocate for cardiac rehabilitation, actually said that there's no question open heart surgery saved my life. There's also a question cardiac rehabilitation taught. So thank you very much to all the faculty for allowing me to speak today, and I'm happy to answer questions.
Dr. Hirsh, thank you so much for that wonderful talk and that tour of conventional cardiac rehabilitation, stretching through to the promise and reality of virtual cardiac rehabilitation. And it's really wonderful what you and your team have been able to construct at Northwell. It's a real resource to your patients, and obviously will help us grow the database to hopefully further implement funding and utilization uptake over time throughout the US and beyond. So one quick question comes to mind. You know, these cardiac rehab, absolutely fantastic, and I love how they're emphasizing quality of life as well. But there's 36 sessions, then the 36 sessions, it comes to an end. And behavior change is one of the holy grails of medicine. We all kind of know that eating more kale is good for us, doing more exercise is good for us, but there are societal headwinds and there are personal headwinds. What are some tricks or tips that maybe you could give us to help us with our patients for them to adopt behavior change?
Yeah, no, and one of the major things that we have to address, Alex Duisberg said that the bigger is in healthcare is that we're trying to come up with the next advance, but we're actually trying to change people's behaviors. Because that's really where you see the impact. So to change people's behaviors, you have to kind of understand where they're coming from. Their local knowledge is obviously on this background, and then listen to them, and really try to say that the most effective way for you not to have continued coronary disease is effective exercise program and diet. I mean, you have to do that in such a way that they understand that they've had heart surgery, heart attacks, heart failure, and if they want to live a longer and better life, they have to adopt this, and you have to emphasize that, stress that people are very happy with the program, and develop your own script. So it really comes down to your connection with the patient, and proud of this, how beneficial this is.
Well, thank you. And in addition to the individual hurdles for behavior change, there are societal headwinds that we all face, from inexpensive and easy to access, not so healthful fast food, to environments that may not be safe or amenable to exercise, to reimbursing of rehabilitation programs, as you spoke about. What sort of societal level hurdles, whether it be for food availability or uptake, exercise, further adoption of rehabilitation, do you see on the horizon that can bend the curve in a favorable direction?
So I think you hit it on it. I think that the food industry is really, really bad. Availability for nutrition is just too abundant. There is a lot of interest in many of these organizations to try to change and how we address changing the availability of food and the education about nutrition is obviously a very important question, and one that we have to take steps to address. And certainly I can address it from an individual standpoint with a physician, but those questions have to be answered on a larger scale. And I would be interested actually to hear what you have to say, because I know here you work implementing plant-based diets. So what are your thoughts?
It's a vexing issue, and there's obviously no great answer. New York City will hopefully be a petri dish of experimentation, and given our leadership, that the mayor now of New York City, Eric Adams, is plant-based, and is very interested in promoting that from a health perspective, and he's worked a lot of that into the health and hospital system here. And of course, there are many aligned organizations, and Montefiore certainly supports pursuing further health, and we have a variety of plant-based initiatives and other health initiatives here to try to help bend the curve. So it'll be interesting to see what his various initiatives reveal in terms of cost and outcomes. But I share your concern. I mean, when you're up against the headwind of a farm bill, for example, that's maybe $40–50 billion that in some level is supporting animal agribusiness, it's hard to take that on as an individual physician. And on an individual level, we certainly work with our patients, ask, buy in bulk, don't talk about organic because that could be quite cost prohibitive, and talk about easy ways for them to bulk cook and make meals that are not going to be too onerous on a very busy life. But in terms of bending the societal needle, I don't have a great answer for that. But what I'm hoping is that New York City leads the world in lots of different ways, and hopefully this will be one of the ways that it does it. And on another angle of it, of course, is the environmental aspect, because who cares how healthy you are? No planet, no health. And of course, animal agribusiness promotes more global warming than all transportation combined, which of course includes cars. So perhaps that'll be a motivator for people as well. So it's a tough question. I don't have a great answer, but obviously there's interesting work afoot.
And just to add one more element to it, it's also about people's early life, right? I mean, what they see their parents eat, how their parents give them. So, I mean, not to keep mentioning Valentine Booster again, but he got a $5 million NIH grant to basically teach children and their parents how to eat healthy diets and foods, to be able to supplement them with healthy diets, and to really try to address this question even at the age of 3, so that they grow up getting babies with the fact that they should be eating these types of food. They model their parents, and the parents follow suit. So I think initiatives like that, where you really start prevention very early, is something that is going to be.
I think you bring up a great point. It's coming at it from multiple different angles, maybe death by 1,000 paper cuts, if you will. We'll bend the curve for us. But I don't see any other questions up here. My apologies if I'm missing any. I don't see any here. But so thank you so much for this wonderful and incredibly important talk, and kudos to you and your team for the incredible accomplishments that you've made at North Shore and beyond.
Thanks very much. I appreciate the kind words.
Thank you. And the CME, I think Millie's going to put the CME up very shortly. I think at the end of the talk is my understanding. There you go. All right. Thank you so much, Dr. Hirsh.
Thanks very much. Are we still recording, right?
Yes, we are still recording.
I'll talk to you later.
Okay. So you can't have your Big Mac right now.